2 and we'll just start.
Okay.
25 people I can see online right now.
Kiran May is still traveling?
Yes.
Yes, that's the reason I took the last two, Jyoti.
Okay. And the other
Yeah,
one I will
Kiran.
take on the 7th. I will take it.
Kiran, that is not fair. Yeah. The reason for that is, see,
Sir?
one of your main babies is one main topic, you know, which is something which you have close to your heart. The one which is related to challenging situations. And
Sir, yeah, why I didn't promise this? Yeah, why I didn't promise is it's quite unpredictable, you know. So if I promise and I don't reach home, so if I reach home, maybe. But anyway, everything is fixed now.
yeah,
You
okay.
know, I was thinking to pick up more topics, but then
No worries, no worries. So long as, you know, these are the only 3 sessions of master
Yes.
training. That's about it. I can see Kiran is also there. Good to see you, Kiran. Kiran is from Kanpur, for all those who...
Kiran Pandey.
Yeah, Kiran Pandey. She's from Kanpur. And I can see Monica also. Good to see you, Monica. Yeah. I can see Kanchan also. Kanchan, I'm depending on you to take the process forward. Huh? You're muted, Kanchan.
You're muted.
Good afternoon, sir. Sure, sir. I would love to.
Yeah, Kanchan is the flag bearer. She combined 7 societies together to do our RAC program. And then Mandakini Meg also, you know, browbeaten her. You know, Kanchan you have to do in Maharashtra also. So Kanchan, poor girl, had to do in Maharashtra also 7 societies.
In Maharashtra, it was 17, sir. It was 16,
17.
17.
No, but 17 years, but only about 7 people from the societies had joined, not 17. 17
Yes, sir.
years, everybody took their honorarium and nobody joined.
I was there in both the programs.
Yeah.
Yes, yes,
You-
ma'am. Yes, ma'am. Good evening. Good afternoon, ma'am.
So
You
this
please tell
also
Mandakini Meg, I was making this wild comment on the group call. Okay, I think with that, I think we have about 25 of us. That's good enough for us to
I
start.
think they'll all join a little late.
Yeah. So good afternoon, everyone. Once again, thank you very much for joining in. It's been an absolute delight to once again reconnect with each one of you. Several of you have met recently at the AICOG, and thereafter we have been in constant touch. It's such a pleasure to see all the Dheera OBGYN team members who have made this entire curriculum possible and has been, you know, at the forefront of leading this entire initiative, which has been the flagship program of our beloved president, Dr. Shanta Kumari, without whom we wouldn't be sitting here and we wouldn't be having the kind of funding that is required from UNICEF and wouldn't have been able to carry forward this program. So welcome each one of you once again. Just to quickly throw a couple of numbers for you, Dheera has begun extremely well. The Dheera school program has gone across to 125 schools so far, and we have trained about 15,000 students all India. We are hoping that from June onwards, the entire pace will pick up once the schools again start. On the master training front, we have about 600 Dheera master trainers for the school, and that is a wonderful thing for all of us. And these are the individuals who are, you know, constantly volunteering and taking up the program. I'm hoping the team who is sitting here today getting trained in this master training program will also be taking forward the entire initiative for the OBGYNs of our society in several societies as we go along. So that's on the Dheera master training bit. On the OBGYN training bit, we did one master training session on 1st of April or 2nd of April, where we have trained about 40 people so far. So that again is a huge kudos to everyone here and those who joined in. I'm sure each one of you will be the flag bearers to take this whole process forward. With that, Yeah, with that, I will request Vindhya to please take over and walk us through the first session and begin the entire proceedings for the day. Thank you.
कोई बोतल लगी बात है अभी देखा दीदी हो गई बोतल लगी ठीक
And while Vindhya is getting her
See my slides.
Yes, we can see your slides, please. Yeah.
Today's topic, as already Ajay has told, it's violence against women, and I'm dealing with the overview of what is and of violence against women. So we sincerely thank all the core group who have made this possible, all these presentations, and starting with Shanta Kumari, Kiran, Ajay, Ramani Devi, Raki, and all the rest of Rohan, Krishnendra, and Aruna. So gender-based violence is the most pervasive yet least visible human rights violation in the world. So I want you all to put these in the chat box, and what forms of gender-based violence are experienced as a woman and girls. Please put your answers in the chat box if possible.
बैलेंस पे ही है ये Yeah.
Where can women and girls experience gender-based violence? Which age groups may experience gender-based violence? So I'll look at these chat boxes a little later. So what do we understand by violence against women? Violence against women means any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such acts, coercion, or arbitrary deprivation of liberty. Even not letting them go out and locking them at home is violence, whether occurring in public or in private life. So violence against women encompasses, but not limited to, physical or sexual and psychological violence. It can be in the family, community, or perpetrated or condoned by the state, wherever it occurs. So the types of violence are physical violence, that is kicking, biting, slapping, beating, strangling. And these can actually, when the patient comes to us, we can actually see at times women are seriously injured. And then they, even in maternity cases, they may die out of these. And when we go into the history, we know that it is the violence which was at home, gender-based violence or violence at home. And psychological violence is preventing a woman from seeing family and friends, belittlement or humiliation. And you can imagine the various scenes of belittlement or humiliation, so many times, so many scenes. And economic restrictions, violence of threat against cherished objects, and other forms of controlling behaviors also. And sexual violence, as we all know, is forced sex using physical force, threats, intimidation, and forced participation in degrading sexual acts, or denial of the right to use contraceptives or any other method to protect themselves against transmitted diseases. So this is the prevalence across the globe. It ranges from 25 to almost 40%. And which is, even in Southeast Asia, it's about 37.7%. Whereas in the American region, it is about 29-30%. So see, it is prevalent across the globe, almost the same percentage. An intimate partner violence, physical or sexual violence at any intimate partner in their lifetime in Southeast Asia, these are the statistics. And in India, it is about 28.8%. And the highest being in Bangladesh, which is 54.2%. And in Afghanistan, it's about 50.8%. This is only in Southeast Asia. So this is gender-based violence is underreported. It's only a tip of the iceberg what we see. So DHS survey data from 24 countries collected from 2004 to 11 shows that 40% of the women experienced GBV previously disclosed to someone, a friend or family or someone, but only 7% report to a formal source, that is the police or the legal person. When it comes to India and Southeast Asia, it's about 2% and 14% in Latin America and Caribbean. So when it comes to the cycle of abuse, it can start from infancy then from pre-birth, infancy, childhood, and adolescence. So in pre-birth is sex selection abortions, effect of battering or pregnancy and childhood, which can lead to abortions or IUDs. And in infancy is female infanticide, physical, sexual, or psychological abuse. And in girlhood, it is child marriages, female genital mutilation, and physical, sexual, and psychological abuse, incest, child prostitution, and pornography. And in adolescents and a little older girls, it is trafficking, honor killings, partner violence, marital rape, dowry, murders, abuse of women with disabilities, rape, sexual harassment, forced prostitution, and pornography. Forced pregnancy, acid throwing and date raping, and economically coerced sex, incest, sexual abuse in the workplace is also very common. So 20% of the women experience child sexual abuse. So health impacts of gender-based violence on the individual can be physical or reproductive. So when it comes to physical, it can be an injury, shock, disease, infection. There can be weight loss or gain or regressive behaviors, or not eating or eating all the time. These are all the mental problems. And the chronic physical illness can be disability, chronic pain, gastrointestinal disorders, that is irritable bowel syndrome or any other forms of gastrointestinal disorders, eating disorders, sleep disorders, chronic fatigue. When it comes to reproductive, it is miscarriage, unwanted pregnancies, unsafe abortions, STIs, including HIV, menstrual disorders, pregnancy complications, and other gynecological disorders. So it can be effects beyond the individual survivor. So it can go to the children, family, society, everything. So effects on the children of women who experience abuse are higher rates of infant mortality. Behavioral problems can be there in those children of affected women. Anxiety, depression, attempted suicide, poor school performance can be there. If the situation is bad at home, it will be this poor performance in school. Physical injuries or health complaints, experiencing or perpetrating violence as adults. They think it is the right thing to do, so it's going on at home. So when they become adults, they also imitate the family members. So effects of the families are fractured family relationships, safe care if abuse happened in the home. Safety of the family is very important. Housing instability, co-occurring violence, poorer collective health and coping. So effects on community and society are the cost of services incurred by victims and families, like for health, social, and justice, all these are high. Loss of education and potential development and contribution by child as they become an adult. So perpetration of violence in the community. So higher crime rates, burden on safety and justice sectors. So where and how do violence and HIV/AIDS intersect? That is, it can be a direct transmission through sexual violence, types of sexual exposure, presence of other STIs, degree of trauma also. And indirect transmission is through sexual risk taking. Violence is linked to increased risk taking, multiple partners, non-primary partners also. And indirect transmission through inability to negotiate condom use. Women find it difficult to suggest or insist on condom use in face or threat of violence. So intimate partner violence can be physical trauma, psychological, or fear and control. So physical trauma is, we all know all the injuries, soft tissue, genital trauma and others. And whereas psychological is mental health. Physical trauma also can lead to psychological or mental health problems. Like anxiety, depression, eating disorders, suicidal tendencies, and they may lead to substance abuse like alcohol and any other substances, and which may also lead to non-communicable diseases like cardiovascular disease, hypertension, maybe diabetes also because of the stress. And the somatoform are other gastrointestinal problems, chronic pains, etc. And the fear and control is limited sexual and reproductive control, lack of contraception and unsafe sex. And healthcare seeking is lack of autonomy, difficulties seeking care and other services. And such people will have difficulties in seeking care. And perinatal and maternal health is low birth weights, prematurity, and pregnancy loss. And sexual and reproductive health is unwanted pregnancies, abortion, HIV. We already discussed about this. And 42% of the women who have experienced physical or sexual violence at the hands of a partner have experienced injuries as a result. And mental health is twice as likely to experience in depression. And almost twice as likely to have alcohol disorders. And 16% more likely to have a low birth weight babies. And twice as likely to have an abortion. And 1.5 times more likely to acquire HIV, and 1.5 times more likely to contract syphilis infection, chlamydia, or other diseases like gonorrhea. And 38% of murders of women globally were reported as being committed by their intimate partners. 4.5 times as likely to attempt suicide. So let's go to some quiz. Statements are intimate partner violence is more prevalent among poor women and girls. Is it a myth or a reality? So the answer being, it's a myth. Studies show that gender-based violence can happen among people of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, friends, even the women next to us. We don't know where it happens. In some instances, especially when it is not severe, beating by a husband can be an effective form of discipline if the wife is acting inappropriately. Is it true or is it a myth?
Myth.
Yes, it's a myth. Gender-based violence is a serious human rights, health and development issues impacting survivors. Human rights, health and development issues impacting survivors, their families, and the health and development of entire communities also. Majority of sexual violence against women and girls is perpetrated by strangers. Is it true? Or is it a myth? I'm not seeing the chat. Should we see the chat, or Ajay, can you see the chat?
Myth, ma'am.
Yeah.
Yeah, I'm seeing the chat. Quite a few written.
Yeah.
Myth.
Okay, then studies consistently show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. And globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. It is safer for a woman to leave a relationship with an abuser than to stay. Is it true? Violence often continues and may even increase after a woman leaves a partner. In fact, a woman's risk of being murdered is greatest immediately after separation. I don't know, Ajay. I think sometimes it may be the other way also. The lady may be more peaceful and a more peaceful life once she leaves the relationship.
Very true. Or, yes.
2 ways. Yeah.
Statistical evidence shows otherwise.
Yeah, otherwise. But many times my advice or whatever, when I counsel, is to leave the marriage, especially if it is a marriage, for them to have a peaceful life ahead.
Yeah, so sure.
Yeah. Gender-based violence is a serious human rights, health, and development issue impacting survivors, their families, and the health and development of the entire communities. So all of you, please do the registration and pre-test, and post-test and feedback also is necessary for you to get the certificates. Thank you.
Thank you so much, India. Good to have you, Raki. After a long time seeing you online here. Yeah. So we have the next one taken up by Raki. Please carry on.
Thank you, Dr. Ajay.
While she's preparing for the showing the slide, Vidya, there have been a lot of correct responses to the Quiz.
Yeah, I think I look at the chart because my screen was not showing the charts.
Yeah.
I will see.
Quite a few correct responses, and I think the thought process and idea gels well with whatever we are going to talk about. Yeah.
Only that last question, I think I was a little not sure. Otherwise, I think everyone knows what they are doing. Yeah. Yes.
True.
Can I start? After the overview of by Dr. Vindhya, let's move on ahead. And today we're going to talk. I'm going to talk on how to approach for a woman facing violence. And ideally, that individual, whoever is facing the violence, either it could be from the family, relations, friends, or the service healthcare providers, from where the violence can be started, or the community maybe there. All these are the different ways from where the woman can be facing the violence. And we need to create an enabling atmosphere and establishing the trust for these patients. The healthcare professionals should always speak directly, looking into the eyes of the patient. She should take a private space and talk to her alone, and recognize her courage in reaching you, as they have already overcome a lot of serious barriers. Recognize the dilemmas faced by the survivor in reporting the violence. Do not label non-reporting to police as a false case. Assure the survivor that the treatment will not be compromised at any end. Inform the survivor of available resources, legal rights, so that they can take an informed decision accordingly. There is a lot of role of the family, friends, in the community for these individuals. The recovery from the violence is dependent on the extent of the support received from the loved ones. The healthcare professionals are the best suited to engage with the family and discuss the ways of promoting survivors' well-being. It should be discussed with all caregivers that the survivor should not be held responsible for the assault. In situation of, say, child sexual abuse, the parents may experience anger, confusion, guilt. Some may also blame themselves for not having given adequate care or paid attention to the child. Reiterate that it is the perpetrators who misuse their position. It is not you who's responsible solely. The role of the healthcare providers is all the women are likely to seek help from the healthcare services at some point in their life or the other. Healthcare providers are often trusted by the women and serve as a role model in the community. So violence is an underlying cause of injury or ill health. They come to us, so we need to be open, and we should be welcoming them to speak more. Facilitation and demystification of medical procedures. The healthcare professionals should prepare the survivor for an internal examination, explain in detail, counsel the patient about the various stages of the examination. Communication has to be done for the rationale, for the referral, for the x-rays, ultrasound for the ultrasound, age estimation, and all the other investigations what all are required for the survivor. Addressing the survivor's emotional well-being is an important important step, which is to be taken up by the service providers. The healthcare professionals should recognize the survivor and may present varied emotions, encourage the survivor to express her feelings, encourage the survivor to seek crisis counseling, assess of suicidal ideation, make a safety assessment and safety plan, involve family and friends on healing process of the survivor. Ideally, what we as a healthcare providers could take, we can counsel and we can tell them that take your own time, share only what you would like to share. I can imagine that you have been really hard for you. It has been really hard for you. It takes a tremendous amount of strength to share what is happening to you. How do you think we can help you? You are not alone. This way the patient may open up. And on the practical aspect, practical concepts, we can have a solar approach. The solar S stands for sitting position, opening posture, leaning forward, have an eye contact with the patient, be relaxed, and supporting the gender-based violence survivor using the lives approach needs to be given. Lives L stands for listen. Listen in depth to the patient with full of attention. Inquire, validate, enhance safety and support. In the in the listening part, use the verbal and the non-verbal means to show the support and communication and understanding. Like, ask the questions, the open-end questions need to be asked, focused, and it should be closed. Use good body language or the posture and eye contact. Avoid leading questions and compounding questions to these patients. Eyes, give her your undivided attention. With the ears, truly hearing her concerns altogether, and heart with a caring and respect needs to be done. There are some amount of do's and don'ts in the listening, how to act and how we are not supposed to act. Be patient and calm. Let the client tell her story at her own, and do not pressure her to tell her story. Let her know you are listening through the verbal and non-verbal clues. For example, nod your head and say, maintain gentle and appropriate eye contact. Do not look at your watch or speak too rapidly. Don't answer the telephone. Look at a computer or write when the patient is talking to you. Our attitude makes a difference. Acknowledge how she's feeling. Don't judge the patient, what she has or has not done, on how she is feeling. Don't say you shouldn't feel that way. You should feel lucky you survived. We are not supposed to tell that way. What we are supposed to say is give her the opportunity to say what she wants. Ask her, how can we help you? Encourage her to keep talking if she wishes to talk still further. Don't assume that you know what is best for her. Don't interrupt her. Wait until she has finished before we move on further ahead. And allow for the silence. Give her some time to think. Don't try to finish her thoughts and cut short of her thoughts. Stay focused on the experience and on offering the support. Don't tell her about someone else's story or talk about your own troubles. Acknowledge what she wants and respects her wishes. Don't think and act if you must solve their problems for her. Inquire about the needs and the concerns. Phrase your question as an invitation to speak. Ask open-ended questions instead of yes or no question answers. Check your understanding by restarting what he says accordingly. Reflect back to the client the feeling they express. Explore as needed. Ask for clarification if you don't understand. Help her to identify and express her needs and concerns. Sum up what she has told so that we and the patient are both in the same line. Ideally, what you say is, what would you like to talk about? How would you feel about it? Feel about that? You mentioned that you feel very frustrated. It sounds as if you're feeling very angry about that. Could you tell me more about that? Can you explain that again, please? Is there anything that you need or are you concerned about? You seems to be saying that. These are some of the leading questions what we could ask for these patients. V stands for validate. Validate does not mean to try and verify the survivor's story, for example, through interviewing or alleged perpetrators or witnesses. This is not safe, appropriate, ethical, or recommended. Show that you understand and believe them. It's not your fault. You are not to be blamed. You did the most important thing you could do in that moment you survived. Help is always available. No one deserves to be hit by their partner. You are not alone. Unfortunate, many others face this problem. What happened has no justification or excuse. Your life, your health, are your values. Everybody deserves to feel safe at home. I am not worried that it may be affecting your health. I am worried. We need to tell that way. It's okay to talk. Empathy and sympathy are there to create boundaries. Sympathy is a personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. It is identifying the survivor's experience through your own shoes. Empathy implies to intellectual, personal understanding and realistic professional distances. It involves compassion and objectivity and leaves room for empowerment of the survivor. It is the attempt to put oneself in the survivor's shoes. Dealing with the emergency situation during the approach, we need to apply the lives approach for these. The challenging issues while dealing would be the providers are not responsible for if the survivor tells you that their abuser has threatened to harm them. What should you do? Put your thoughts in the chat box, please. A few ideas. Ask concentrate questions about safety risk, but only when there is a privacy. Ask if the survivor has safety plans in place in case she needs to flee. Discuss potential strategies for being able to leave her situation safely. Provide a referral to a gender-based violence expert agency for additional help if possible. There are various challenging issues where the survivor expresses the suicidal tendencies and be able to recognize the signs of depression and the suicide risk. Do not be afraid to ask, are you having suicide thoughts? If the answer is yes, then do take it seriously. Do not leave the suicidal survivor alone if there is an immediate danger. Always consult a supervisor about how to refer or manage a suicidal survivor. Never make a decision on your own. This is for your own safety and well-being also. Provide referral to the gender-based violence expert agency for additional help if possible. We as providers are not responsible for it. We need to approach. Ignoring the violence can do more harm. There are the provider's behavior and then the consequences which are there. Blames or disrespect women or the girls can inflict additional emotional distress or the trauma. If we don't recognize a gender-based violence behind chronic or recurring conditions, then the woman receives an inappropriate or inadequate medical care. Fails to provide post-rape care or address the gender-based violence in family planning, in the STIs, HIV care, unwanted pregnancies, STIs, HIV, safe abortions, and more violence would be the consequences of it. Breach the privacy or the confidentiality, the partner or the family member becomes violent after overhearing the information. Ignores the signs of fear or emotional distress, the woman is later injured, killed, or commits suicide. So we need to be careful with all these. The doctor helped me feel better by saying that I don't deserve this treatment, and he helped me to make a plan to leave the house the next time my husband became violent. I present to you this quote. Warm referral practices help the woman reach further care. Basically, the warm referral, there are various helplines in the support system, what we're going to come for, look forward in the rest of the lectures. With the healthcare support system is there, psychosocial support system is there, legal and the justice support system is in place, and the security support system is also in place. Thank you all.
Yeah, thank you so much, Raki. I think the first two sessions hit upon the very, very critical aspects, not only in terms of the overall, magnitude of this issue across the country, whether it is urban areas, rural areas, whether it is, any kind of geographic spread, and it is critical that it needs to be addressed, and more addressing from an OBGYN perspective, and which is what Raki covered. Lives approach, I'm sure you must be doing it in some form or the other, but there's a complete science to it and an art to it. and which is what we have walked you through. And if you are able to take something out of that from the lives approach, I'm sure it will be in the benefit for our patients or the women who come seeking help from each one of you. With that, I call upon Vindhya to walk us through the third session of the module 1.
Yeah, thank you, Ajay. Yeah. This is, can you see my slides?
Yes, please.
Yes, madam. Yes, ma'am.
Effects of violence against women on pregnancy and newborn is the topic. Have you ever seen patients in your OPD who have been victims of violence or abuse? So we all have, I think we'll go back into our, we'll remember some cases or something with these violence cases. How do they present? How have you diagnosed them? What are the common clinical presentations? Can you recollect a case scene? I think all of us can. So the causes of maternal death can be many. All these can be there, severe bleeding, infection, all these. 90% of the deaths are avoidable. But what is behind these causes? So behind these causes, maybe many times, when the patient comes and there's a maternal death with bleeding or rupture uterus, maybe it is an accident, not an accident, or it is not physiological or any pathological, but it is a violence at home. So high levels of violence during pregnancy. So this is phrased told by a woman in Peru, but we can reflect this in many of our patients across the globe. Even some of our patients, we can hear this. He hit me in the belly and made me miscarry 2 babies. I went to the hospital with heavy bleeding and they cleaned me up. This so many times we see, and Dr. Kiran Mai keeps on telling us about these patients in her hospital, how they come and have bleeding and then have a miscarriage. So this is a case 1, a primary with PROM, prolonged and obstructive labor, presented with rupture uterus, shock, and there was a maternal mortality. So the history later on revealed that history of brutal kicking on the abdomen by husband and pushed violently, falling on a sharp edge. The death was due to this violence. So the case 2 is Gravida 3, Para 2, 28 weeks, so 28 weeks with 2 previous cesareans. She had an antepartum hemorrhage, shock, placenta accreta. Hysterectomy had to be done. 10 blood transfusions and bladder involvement was there. So what precipitated bleeding in this case is husband kicking on the abdomen. The case 3 is a woman with severe preeclampsia and unconscious eclampsia with CVA leading to maternal mortality. Death due to, we all thought it was death due to eclampsia, but actually the violence was the cause. And postpartum, there was a fractured skull and cerebral hemorrhage. Direct death due to violence, and it is not due to eclampsia. And hidden violence masquerading as maternal disorders. So the 4th case is a Gravida 3, Para 2, previous 2 LSCS, full-term pregnancy. She had a rod implanted, fracture femur and in the hip joint. She collapsed in front of the hotel, brought to the hospital by 108, in active labor with severe hypertension. So the emergency LSCS was done and the consent was given by the RMO. So she was actually pushed from the 2nd floor of the building. And the history revealed that she was pushed 3 years back by from the 2nd floor of the building, now abandoned in labor. So the 5th case is Gravida 3, Para 2, and she has no living children with 2 previous LSCS, 36 weeks, severe anemia. So both times a history of physical violence, kicking on the abdomen brutally by the husband, followed by loss of fetal movements. 3rd pregnancy, parents brought her home. transfused blood, and a cesarean was done with a live baby. So the sixth case is a gravida 6 with para 2, 3 abortions, 2 previous sections, 3 induced abortions, and acute hemorrhage, shock, sepsis, and incomplete abortion. So severe form of physical, emotional, and violence forced abortions. Abandonment. Brought out only by screening. So received 4 transfusions. So these are the pictures. You can see the face, there's injury on the face and a cut injury on the uterus. So stab injury, husband inebriated condition, lacerations on the face, perforation of the uterus, IUFD, and laparotomy, and the repair of the rent was done. So unique obstetrician and gynecologist, a specialist stakeholder in women's health. We are unique in this position to assess and provide support for the women who experience violence because of the nature of the patient-physician relationship. So many opportunities for intervention that occur during the course. Adolescents, these patients come throughout their life to us in various stages of their life. Adolescence, pregnancy, and they come for interpregnancy, they come for family planning, annual examinations, and other health issues also they come to us. And how do we elicit history? We ask indirect questions. The following may be helpful. Is there everything all right at home? Are you getting on with your partner? The screening tools are various screening tools, the abuse assessment screen, humiliation, afraid, rape, kick screen, hurt, insult, threaten screen. All these are the different tools we can use as a screening procedure for all these women. So the WHO recommends that all health professionals be trained in first-line response to family violence. The steps are to listen, believe, inquire about needs, validate a person's experience, enhance safety, and offer ongoing support. Universal screening or routine inquiry, asking all women at all healthcare counters about intimate partner violence is not recommended. However, the WHO guidelines.
Your screen is not seen.
Is it? Why?
Vindhya, your screen is, yes. Yeah, because only it stopped at WHO 2018. It's not moving from there.
Is it seen the next slide?
That is the, yeah.
Is moving?
Yes, ensure safety I can see.
Yes, we can see.
You can
see.
Yeah.
We can see it's moving as
So
well.
it is not necessary and mandatory to ask them about intimate partner violence for all patients. But however, in antenatal, when they come for antenatal checkups, as a setting where routine inquiry could be implemented if providers are well trained on a first line response and minimum requirements are met. So we have to ensure safety, and the evidence on benefits and potential harms of clinical inquiry and subsequent interventions is lacking or uncertain. A minimum condition for healthcare providers to ask women about violence is that it must be safe to do so. Like asking questions also, we should see that they are safe. We can't ask these questions in front of anyone. That is, the partner is not present, and that identification of IPV is followed by an appropriate response. So detailed guidance on responding to IPV and sexual violence against women can be found in 2013 WHO clinical and policy guidelines. All of you can refer. So registration and pre-test is necessary and post-test feedback for you all to get the certificates. So many women in many parts of the world speak the same language, the language of silence. This is what is told by Anasuya Sen-Gupta. And it's up to us, obstetricians and gynecologists, to be the voice of the silent victim. Thank you.
Thank you so much, Vindhya. It's been absolutely great learning about all of this aspects related to the first module, through which we covered 3 important topics for each one of us. And the last statement is so powerful, and the onus definitely is on us to see how we can elicit the right kind of response to be able to help with empathy rather than sympathy, which is what is something which needs to go forward with. With that, we move on to another very, very important topic. It's related to mental health issues through this entire module, and which is what we need to ensure that we are able to cover going forward. I'll invite Ramani Devi to please walk us through this particular session.
Good evening, everybody. Hope you are able to see my screen.
Yes, we are able to. We'll have to make it.
Yes.
Yes. First of all, let me thank the Dheera team, our dynamic president, Dr. Shantakumari, and all the participants, and Dr. Ajay sir, for having initiated this very important program. I think every obstetrician and gynecologist should know the basics of violence against women. And there are so many issues. And the previous speakers, Dr. Vindhya had given an overview, then followed by Rocky and again Vindhya regarding the basic things, what we need to do when we come across a woman with domestic violence or some sort of intimate partner violence. Now, let us move on to the very, very important topic issue, that is the mental health issue that is being faced by the women who suffer from this violence. So to begin with my talk, let me present a case report. Mrs. R, 26-year-old woman, she was brought to the hospital with complaints of sudden abdominal pain. She was 28 weeks pregnant and married for 1 year, and she was a primigravida. She was a booked antenatal patient. She's a non-diabetic, non-hypertensive patient. And on the very first look, the patient was looking very, very depressed. Her vitals were stable. On clinical examination, uterus was 28 weeks, irritable, fetal heart was normal. Vaginal examination was unremarkable. On inquiry, she came out with a history of being beaten by her husband, because every time she was just a very sweet girl and never used to come and have a very good chat with all the front office people, everybody. But this time she seemed to be bit depressed. That itself has given a clue that something abnormal has happened to her. So what are the details to be gathered from this patient? Whether we need to inform the police if we come across such an event. Then how to counsel the patient? What are the problems the patient can come across? And does she need a family counseling? Any drugs can be suggested for her to come out of this mental issues. Then what are all the aftermath of intimate partner violence? Put your comments in the chat box.
Can we have some inputs here, please?
Yeah, I'm just seeing the chat box, but there are still no inputs. Okay, then let me move on to the next slide. So this particular woman, she is in need of triad of consultation. She has to be seen by her friendly OBGYN. She has to have a counseling with a psychiatrist and a psychologist. Why mental support is needed? Because post-traumatic stress disorder, perceived life threats or injury, there is hypervigilance. There can be mood disorders like depression, suicidal tendencies, and the woman can be substance abuse can happen in that particular person, and there can be a sexual disorder, or there can be phobias, there can be functional GI symptoms or dissociation of symptoms like abnormal behavior can be there, and ultimately there may be social withdrawal of that particular person from all the family members as well as from the surrounding. So first line support mainly has to be provided by the obstetricians and the gynecologists. So what is the role of obstetrician? First thing is we have to go ahead with the risk assessment. How frequently this happens? What is the severity of this domestic violence or intimate partner violence, and how chronic it has been? Safety. Next factor is safety from further assault from partner, psychological screening, suicide, and danger assessment. That is, we are in a position to safeguard the particular woman to prevent further assault from her partner, and she needs a psychological screening, and we have to protect her from suicidal tendencies, and we need to assess the danger assessment has to be done. Also, we have to assess the domestic homicide risk. That is also possible. So the danger signs are frequency of intimate partner violence, presence of severity of the injuries. Sometimes the injuries can be so bad the patient can have fractures or etc., deep injuries. And in pregnant women, the chances of rupture of uterus, fetal heart absence, the fetus going in fire, IUD, all those things can happen. Again, alcohol misuse, threatening to kill, then sexual violence, suicidal ideation in the women, and access to weapon. Sometimes these women, they can have any access to the women, they can have self-inflicted wounds, or the perpetrator can have injure that particular woman. So morbid jealousy in the partner can also happen. So then if you come across such patient, when to hospitalize her? So it is first thing is see whether the patient is stable clinically. If she has severe medical injuries, it is always safe to get her hospitalized. Then you look into the suicidal tendencies or the homicidal probabilities that can happen to that woman, and dissociative or psychotic symptoms, and they become very much depressed, or they become hyperactive, hypervigilant. All those things are not very good. Again, mood instability, affective dysregulation, and self-destructive behaviors, and serious threat to the patient's life. These are all some of the indications which we need to hospitalize these women. Again, the treatment should be individualized, multidisciplinary. Primary treatment modalities are safety assessment, suicide and danger assessment. First, how far the patient is safe, whether she is safe physically, or whether she has got any suicidal tendencies, or whether she is at a risk of developing dangers from the surroundings. All these things we have to assess. Milieu therapy, we have to stabilize the mood of the patient. We have to medication evaluation should be done, and psychosocial support has to be given. Again, always there is a need for a rape kit, photo documentation, reporting legal concerns whenever it is needed. So what is trauma recovery clinic? The objective of the trauma recovery clinic is it enables the survivors to come to terms with trauma, reclaim lives by reducing the emotional symptoms of trauma, enhancing self-esteem and resilience, improving social support, prevent re-traumatization, conduct awareness and capacity building programs for psychologists and counselors. So the most important thing is the patient should be evaluated completely. She should be given a mental support, psychological support that will enhance her self-esteem, and social support should be given, and there should be prevention of repeated trauma to these patients. We can also have such clinics in any multidisciplinary centers, which is going to be the need of the hour. There are few examples of such centers. One such center is what is seen in Nimmans, Bengaluru. The psychosocial impact, what happens? First thing is the feeling of helplessness by the patient. Again, progressive erosion of confidence and self-esteem caused by abuse. So the patient becomes, because of repeated abuse, she loses the self-confidence, self-esteem, and she also has a feeling of guilt on the other hand, And shame and isolation. She is very much ashamed, and she keeps herself isolated from the other family members and from the society also. Traumatic bonding, sometimes paradoxically, it can strengthen the emotional ties to the perpetrators. Physical separation due to increased risk of homicide, this often happens. The woman, once when she sustains some sort of this intimate partner violence, it is always the tendency of the woman to get away from that, physically separated, so that she can keep herself safe from the risk of homicide. Again, decreases coping ability in victims. So the role of the psychologist plays a major one. It plays a main role in treatment. Post-assault psychotherapy is a must. Cognitive behavioral therapy, exposure therapy, and a variant of cognitive behavioral therapy is that it helps the victim to emotionally process assault by decreasing the fear to memories or cues of the event. So once when these women are subjected to this sort of intimate partner violence or domestic violence, her thoughts keeps on reverberating. So with the cognitive behavioral therapy, it is always safe to bring them out of these repetitive memories of this bad event, and it should be the cognitive behavioral therapy should be brief, trauma focused. Accelerate the recovery in victim in acute cases. Then STAR, that is skills training in affective and interpersonal regulation. Psychoeducation about the impact of the trauma on emotions and relationship, and emotion regulation skills should be taught, and effective expression of negative emotions, interpersonal skills related to appropriate assertiveness, development of flexibility in regard to interpersonal expectations, actions, and reactions. Treatment also includes recognition of achievements during the treatment and exercises in self-compassion. Then interpersonal psychotherapy. Interpersonal psychotherapy has been shown to be an effective, non-exposure-based treatment for post-traumatic stress disorders. Many of these post-traumatic stress disorder symptoms reflect interpersonal difficulties such as emotional withdrawal from relationship and individuals. So when she gets exposed to this sort of violence, she is kept under a pressure of post-traumatic stress disorder, where she always tries to withdraw her relationship with the individual or the person who has committed the crime. Interpersonal deficits, that is persistent loneliness, and sometimes resulting in interpersonal hypervigilance. So this interpersonal psychotherapy, again, there are other newer psychotherapies, which includes cognitive processing therapy, eye movement, desensitization, reprocessing, hope, helping to overcome stress disorders through empower, educate, to try to overcome the stress disorders by educating and empowering these women, and relapse prevention and relationship safety. That is very important. Again, we should always try to prevent the relapse of such incidents, and the proper safety of the relationship between the family members should be established. Psychological therapy, women experiencing intimate partner violence, related depressive disorder or alcohol disorder should receive mental health care as per WHO manual Mental Health Gap Action Program Intervention Guide in 2010. That was delivered by the healthcare professionals with good understanding of violence against women. CBT, that is cognitive behavioral therapy, and this EMDR interventions delivered by healthcare professionals with good understanding of WOW are recommended for women who are no longer experiencing violence but still suffering from post-traumatic stress disorders. The WHO again recommends for depression and other emotionally or medically unexplained complaints. The patients can be given some sort of medication. There is a role for antidepressants and benzodiazepines. Mild and in the initial phase, they may not need anything. But when the patients are moderate to severe depression, then they have to be put on tricyclic antidepressants or fluoxetine. If absence of prior depressive episode, there is no need for drugs in the initial phase. Suppose if the patient is started on drugs for repetitive episodes of this sort of violence, then again they need to continue the treatment for about a period of 9 to 12 months after recovery. Brief, structured psychological interventions like interpersonal therapy, cognitive behavioral therapy, including behavioral activation and problem-solving treatment should be offered to these women. Relaxation training, physical activity, they are very important. Patient should somehow mentally, she should come out of this repeated trauma that has been reverberating in her mind. Again, psychological support after recent traumatic event, psychological debriefing, psychological first aid, and this acute distress should be done. So men group treatment therapy. So that is encouraging the men also to take part in personal responsibilities for the violent behavior. The men should also understand that is they are in a way responsible for this violent attitude and the problems what the women face because of this. The challenge attitudes on belief around the use of violence in a relationship. They're again developing skills for reacting non-violently to others. So increase the awareness of dynamics involved in use of violence. So to conclude, mental health is an issue in that is violence against women, affected women, and thus they need to be addressed along with the physical health. So we request all of you to submit the pre-test and the post-test and the feedback. Then only everybody, the attendee, will be getting the certificate. And thanks for the opportunity given.
We should be thanking you for such a passionate and persuasive talk. It comes out so strongly for you, Ramani Devi, and we really thank you so much for joining us today. And
thank you, sir.
And with that, we get on to the next two topics, which our good colleague and friend Aruna will walk us through. Thank you so much, Aruna, for joining us, please. It's over to you.
Thank you, sir. Thank you, Ajay, sir. Good evening, everyone. I really thank from the bottom of my heart, Dr. Shanta Kumari, Madam, for this vision and mission on Dheera to stop violence against women, which she started in 2016. And I really thank Dr. Ajay Bharadwaj, sir, Mr. Ajay Bharadwaj, sir, for taking the roots all over India, sir, connecting so many schools, teachers, and obstetricians. Thank you so much. I'm trying to share my screen, sir. Are you able to see my screen?
Yes, please.
Yes, yes.
Yeah. So after Vindhya Madam, Dr. Raki, and Dr. Ramani Devi Madam speaking on so many issues, what is war, how to approach a woman facing violence, effects of war on pregnancy and newborn. Now, after mental health issues, women who suffered violence, I'm going to talk about challenging issues when dealing with a survivor who may be feeling hopelessness, having suicidal thoughts, or in harms or a negative way. And what should you do? What should we all do when we face such situation? Being a gynecologist, one of our patients comes to us to our clinic saying that she is in a lot of pain because her mother-in-law is constantly pressurizing her that she must divorce her husband because she's unable to bear children. She feels hopeless and wants to give up. This is a very sad situation. What would we do? And what do you want to say something or just keep quiet or ignore? Please put your answers in the chat box. Okay, about few ideas. What are we supposed to do in such a situation? Be able to recognize the signs of depression and suicide risk. Yes, we have to be very sensitive towards the women. Do not be afraid to ask the direct question, like, are you having thoughts of suicide? Are you depressed? Are you having any negative thoughts? Yes. If the answer is yes, take it very seriously. Let it not go. Do not leave the suicidal survivor alone if there is an immediate danger, or else we'll feel guilty later on. So let us give her a proper support. Always consult a supervisor about how to refer or manage a suicidal survivor. Never make a decision on your own. Let us not take our own decision single-handed. Let us involve more people. This is for your own safety and well-being. Yes, provide a referral to GBV expert. GBV is Gender Biased Violence Agency, or OSC, which is Crisis Single One Station Crisis, for additional help if possible. Obgyns should not ask survivors about suicidal thoughts or attempts. It should encourage suicide attempts. Is it true or false? We all know the answers. Now please post your answers in the chat box. False. Ask about suicidal attempts or thoughts does not increase the suicidal attempts. On the contrary, talking about suicide often reduces the woman's anxiety about the suicidal thoughts and helps her feel understood. That's why we have to be very compassionate towards her, and definitely we have to support her and ask her be more empathetic. If the survivor tells you that their abuser has threatened to harm them, then what should you do? Put your answer in the chat box again. Let us have the interaction. What are you thinking about this? I will tell you the few ideas. Now, what should we do? Ask concrete questions about safety risks, but only when there is privacy. So when we counsel the woman, there should always be a privacy. Nobody should be interrupting. And as Dr. Raki told how to counsel, we have to counsel the woman properly, looking into her eyes with open hands and modified tone. So ask if survivor has a safety plan in place in case she needs to flee. Discuss potential strategies for being able to leave her situation safely. Provide a referral to a GBV expert agency or OSC, that is One-Stop Crisis Center, for additional help if necessary. So don't get involved single-handedly and don't take care of it. You have to involve more people, the counselors and GBV experts, and one-stop crisis management. One of the most helpful techniques for helping the survivor to get out of this emotional state is to ask them closed-end questions that require them to think. So what are closed-end questions, closed-ended questions, and what are open questions? Let us see about it. Closed-end questions, the answer is ready. It will come in single word, that is yes or no. Whereas open-ended question, it means her thoughts will get involved and she will have to answer in many words and put it properly in an answer. So shifts them from one emotional state to a cognitive state. Okay. Should require short answers. The close-ended questions now we are talking about, do not return to open-ended questions unless the survivor feels comfortable and has some degree of emotional control. So initially we start with close-ended questions and later on we should come to the open-ended questions. What are some examples of close-ended questions that you might go to in a situation like this? Ideas in the chat. For example, these are the closed-ended questions. How many kids do you have? How are you? How are they in school right now? What are the ages, and the personal questions like that to get more attachment towards the women. Challenging issues when dealing with a survivor who may be mentally ill. Already Ramani madam told us about the mental issues that a woman will face. Let us see few of them. State clearly who you are and what your role is. So you have to Clearly explain your role, how you can help her. Be empathetic towards her. Be empathetic, non-threatening, sincere in your intention to help, and let us not be judgmental. Give honest, factual answers whenever necessary. If you do not know, say so. Just say, I don't know. Do not belittle concerns which the survivor raises. Do not give advices as to handle of their psychological problems. Attempt to be supportive in comments and gestures. Do not assume mentally ill people should know better, or on the other hand, that they need to be told what to do. Be careful about making any assumptions. Know how to activate emergency mental health backup. That is more important. So you have to bring down your knowledge, get into the woman level and speak to her in an open way. Additional challenges, issues. What do you think? Can you be a part of meditation process? Remember, meditation is not recommended as response to GBV. Yes, because we should not subdue the woman and say you're facing, you have to undergo all this and you can tolerate violence. Don't give such answers and don't let her understand that is right. Remember, health workers are part of a survivor-centered referral mechanism, because we all are the first contacts. The women will come to us thinking us as a friend who can confide in us. So we have to properly guide us what to do, what not to do. The meditation process itself maintains and contributes to an abuser's ongoing power and control over the survivor. The abuser may think she's more subdued, she's calm, I can do more. No. The process of meditation presumes that both parties can speak freely, confidently, and safely. That is not the case. Meditation rarely results in an end to the abuser's violence and can actually lead to an increase in violence. That's what I told you. It's unlikely that the survivor's rights will be respected. So being calm and tolerating everything is not the answer. Core safety precautions when dealing with challenging issues or cases. Multiple people can handle difficulty better, more effectively than one person. We have to involve more people, as we thought, the counselors, the one-stop crisis people, whoever are there, whoever are available, and the experts. A service provider should never feel like he must work alone with the survivor. The service provider should not work with both the perpetrator and survivor, not at the same time. Keep the office door open of leaving the office or home if feeling unsafe. Yes, keep the doors open. Establishing a code, like a code word with co-workers to identify unsafe situations, and you have to speak out the code word so that everyone will come and help us. Establish a relationship with local police or security. Use buddy system at work. Yes, have a WhatsApp group and immediately alert them if you are in danger, and to and from work, and if doing some home visits. So use supervision to address security concerns. A group of people can address security more effectively than an individual. So always being in group is more important, and communicating, helping the women in group is important. Coming to the self-care for the provider, it is critical for you. Yes. What can we do? Do you know what is vicarious trauma? Put your comments in the chat box, please. Yes or no. Do you know what is vicarious trauma? Let us see what it is. As a service provider, you should be aware of it for self-care. Defining vicarious trauma. So let us know what is vicarious trauma. A change in a service provider's inner space as a result of emotional engagement with survivors of trauma and hearing their stories. Yes, when we come continuously have such stories, listening to them, getting involved with them, we ourselves might get affected. We become more depressed. Why is this happening? We should not go in a negative way. We should be mentally stable, accept it and analyze it. Changes that occur in the service provider's physical, emotional, or behavioral states as a result of constant exposure to the traumatic stories or events. This should be handled properly. When we were doing duties at government maternity hospital, which comes under Osmania Medical College, during every duty, we used to have these rape cases. It was really haunting, very terrible. Few months we used to have that going on in our brain. So it was very, very difficult. We should be definitely strong and analyze the situation, and we can see how we can help them. Coming to the causes of vicarious trauma, constant exposures to stories of trauma, desire to help change survivor's situation, feeling powerless when a service provider does not see positive changes in a survivor's situation, overlied identifying with survivors, thinking that the service providers has the power to change a survivor's situation. This is not the case in every case. Maybe we can be empathetic, but cannot always help them. Preventing and managing vicarious trauma. The mnemonic ABC should be remembered. A, awareness, being attuned to one's needs, limits, emotions, and resources. Practice self-acceptance. Balance, maintaining balance among activities, especially work, play, and rest in the family. Connection, maintaining supportive relationships. Communication is a part of connection and breaks the silence of acknowledged pain. These connections help prevent isolation and increase validation and hope. So definitely the communication is good. Self-care for health provider. Creating boundaries in the workplace, establishing support within the work environment, like having good friends whom you can rely on, and definitely they will give a good support. Seeking assistance from outside agencies, creating our own self-care plans and following them through. So we should have a strategy to help ourselves and the survivor also. Empathy versus sympathy. So let us see what do we understand by saying empathy or sympathy, and which is better. Pick which statement describes sympathy and which statement describes empathy. Statement 1. A personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. This is what? Empathy or sympathy? Please guess. And statement 2, an intellectual personal understanding and realistic professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. So you please put it in the chat box, which is empathy and which is sympathy. We'll see who is correct. Sympathy is personal, emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. So we have to understand this. It is identifying with the survivor's experience through your own shoes. What is empathy? Empathy implies intellectual personal understanding and realistic professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. Now you understand what is empathy, sympathy, and which is good. Sympathy is better or empathy is better. Always empathy is better. It is the attempt to put oneself in survivor's shoes. So how do you take care of yourself? Please put it in the chat box and let us see how we are going to put up in such a situations, how you're going to act and find answers for you, and how you can act and come out of it. Please use some relaxation and self-care techniques and put it in the chat box so that we can spread.
That is such a powerful, sorry, go on, sorry.
Registration and pre-test, post-test and feedback are very, very important. The certificate will be awarded to participants on course attendance and submission of registration, pre-test, post-test and feedback. Thank you so much.
Thank you so much, Aruna. That was such a powerful presentation, and you have done it at, with so much of weight, I would say, so relaxed in presenting all of this. It's really so nice to see that. And I couldn't agree with you more that many times, we forget ourselves in the melee of things or in the busyness of things, and we do not take care of ourselves, which, is so critical in today's environment that we live in, and what all we face across, even if you do good, you still end up, being someone who is always taken to task from that point of view. Anything else you would like to add, Vindhya or Kiranmai? Please feel free to do that. Or Raki, anyone would like to do that before we move on to the next one, which again Aruna will be walking us through. Vindhya, you're muted.
Kiran, you would like to say something?
No, Aruna, I think you covered it really well. And again, though you have been so extremely clear, and Dr. Aki also told, many times we see ourselves that that sympathy and empathy part of it. I feel I have learned this new in UNICEF GBV course. So we have to be very clear whether we are sympathizing or empathizing. So that is most important point, so that we can be we save ourselves from being vulnerable. At the same time, will not make the survivor or victim feel vulnerable. That sympathy is such a thing, it makes you feel bad, and also the survivor also feels that pity is nobody needs. That kind of expressing pity or showing sympathy, nobody would like to be in that situation. So that is not empowering, whereas empathy will make you feel powerful, as well as makes the survivor also feels empowered. I think that is the most important take home, and you have covered it really well, Aruna. Thank you.
Thank you so much, Kiran. And I thank all those who have prepared these slides. These are really good, Kiran. Congratulations for that. Ramani madam, Jamuna madam, Ajay sir, and Surekha, many more. Thank you so much for all the presentations.
Anita is not there here. Anita Sabarwal is there. And
Anita is here, Jyoti is here.
Jyoti.
Yes, Jyoti Banglawala. There are many who have made these slides really empathetically, and the content is really good.
Question in comment box: where is the service agencies located by Prema Priya? I think Aruna's next talk will address.
Cover it, yes. I will give you all the details. Coming to the second topic, support systems and resources for survivors. These are the slides made by Dr. Anita Sabarwal, Dr. Jyoti Banglawala, Dr. Rohan Palshetka, Dr. Ramani Devi Madam, and curated by Dr. Kiran Mai and Mr. Ajay Bharadwaj. Overview of this section. What are we going to learn? What are the protective laws and acts? What are the helplines that are there? What are OSCC and one-stop crisis centers, and how can we link up and help in rehabilitation of the survivors? The Protection of Women from Domestic Violence Act was from 2005. It's a short title, extent and commencement. What we'll see. The act may be called the Protection of Women from Domestic Violence Act 2005. It extends to the whole of India except the state of Jammu and Kashmir. It shall come into the force on such day one as the central government may by notification in the official gazette appointment. Okay. Why Domestic Violence Act was started? It is 498A into the Indian Penal Code introduced in 1983. There was no emergency relief available to the victim. The remedies available were linked to the matrimonial proceedings, and the court proceedings were always protracted. It was delayed, during which the period victim was invariably at the mercy of the abuser. Relationships outside marriage were not recognized. That's why this Domestic Violence Act was started in 2005. This as a civil law in 498, a husband is liable for punishment, but wife does not get any financial relief. But in domestic violence, wife female partner gets relief, but there is no punishment arrest unless husband violates court order. Another difference in 498A can be booked against husband or his relatives, but domestic violence can be booked only against the male members of the family. Who can be a complainant? A wife, a woman based on consanguinity, marriage, adoption, and cohabitation against a male abuser in a shared household. A woman who is in relationships similar to a marriage with a man. Technically, a transgender male to female could bring an action against a transgender female to male. So this includes even the transgenders. A woman in a live-in relationship with an unmarried man, but not with a man who is married if she knew or ought to have known that he was married. Anyone can file a petition with the survivor's consent. To whom can you complain? Protection officer, service providing center, medical officers in charge, police station, and magistrate. Where can you complain? Jurisdiction under the PWDV Act, where wife permanently or temporarily resides or carries on business or employed, or where husband permanently or temporarily resides or carries on business or employed, or where cause of action has arisen. The wife can choose any of these three options under these and can give a complaint. Types of orders: protection orders, stop violence, emergency relief, residence in shared household irrespective whether she has any right of ownership or lease. There is a case, Batra versus Batra. Can require separate housing and abuser must provide, custody order, compensation order, violation of above order, and offensive, and magistrate may charge offense. Section 31. Non-compliance of a protection order by magistrate can lead to a issuance of non-bailable warrant. Time prescribed by the Act. The Act requires that all proceedings brought under the Act be disposed of within 60 days of the first hearing, which must occur within 3 days of following the application. What are the services that are offered? File a detailed investigation report, direct complaint to a shelter, facilitate free legal services, provide counseling services as required. Domestic legal remedies in India. So there is Constitution of India, Article 14 on equality. The National Commission for Women set up as a statutory body in January 1992 under the National Commission for Women Act 1990, the Dowry Prohibition Act, and 498A IPC that we have been talking about. This is the most widely used provision against domestic violence. The Protection of Women from Domestic Violence Act, PWDVA 2005. Now coming to the concept of one-stop crisis center. What are they exactly? What are the functions of one-stop crisis center? Caters to the immediate medical, legal, psychological needs of the women who are survivors of physical and mental abuse, with an assurance that their consent and confidentiality will be respected and protected. So this is at Gauravi at Madhya Pradesh, a joint initiative of the Department of Public Health and Family Welfare, Government of Madhya Pradesh, and Action 8 supported by Police Department. Gauravi's staff of 10 focuses on the women's needs without compartmentalizing the services. This started in June 2014. Bharosa, this is a big trust in Telangana, very successful one, even tackling the Eve teasing also. This Bharosa Center and She Teams office and work together, and all-in-one for violence against women with police, counselors, psychologists, legal advisor, and with medical help. The helpline is 100 and will be directed to Bharosa if it's violence. A woman can walk in with assurance that her consent and confidentiality will be respected and protected. And the Bharosa team, initially, Shanta Madam has done a program and she has done modules under Bharosa. Services of one-stop crisis center. What are the services that they are providing? Medical treatment, social reintegration, safe custody, shelter home, rehabilitation, psychological counseling, social welfare services, legal support, police assistance, forensic DNA testing, etc. So it contains almost all the services that are necessary for the women. So coming to the numbers, helpline numbers that someone asked just now, all India women helpline, women in distress, 1091, please take a photograph of this and save it. Women's domestic abuse helpline, 181. National Commission for Women, these are the numbers. I'm not going to read out all the numbers. Please take a photograph and save it. And these are the other numbers in different places, like in Andhra Pradesh, Bhumika Women Collective, and Aryanika. This is the email ID, Arunachal Pradesh, Andaman and Nicobar Islands, Bihar. Please take the photograph. And these are the other helpline numbers at different places, various organizations and societies that will help the women in distress. Please take the photograph. And these are few numbers from Gujarat, Himachal Pradesh, Jharkhand, Jammu Kashmir, Karnataka, Kerala. So please take a photograph and save it so that we can help the women in whichever area they belong to or whichever state they belong to. The team has made the slides so well. This is from West Bengal. Again, I'm insisting registration and pre-test, post-test and feedback are very, very important. Certificate will be awarded only after doing all this. Thank you, sir. Thank you, Ajay sir, for this opportunity.
It's an absolute pleasure having you here. Really place yourself so well. Yeah, thank you so much, Aruna, for delivering such a topic which is, is not as much, clinical, or for that matter, nothing related to it is so technical from an OBGYN point of view, but yet is a critical topic. So walking up to me, so much. With that, we come to the last two presentations, which our very own Kiran will be walking us through. Yet another individual who is part of this core team and who has been absolute, passionate about everything that she does related to this program. And she will continue keeping the flag high going forward also, now that she's also in a position of the chair for that particular committee. So we look forward to more such interactions going forward. Kiranmai, over to you. All the very best.
Thank you so much, sir. It has been an absolute pleasure and privilege, and I learned so much having been, part of Shanta Madam's vision and mission all these years. And this UNICEF and this partnership and the whole program is such a learning experience for me too. Thank you so much, sir.
Congratulations, Kiran, for being the committee chairperson. My hearty congratulations. I know you for the best job.
Thank you, Aruna. So I think we have had the 2 modules, which everyone has done a great job. So now we go to the 3rd module, which focuses on the sexual violence specifically. You are able to see my slides?
Yes, please.
I'll just stop the video, sir. I'm on a hotspot. Some
Yes,
problem
please.
with
Yes,
it.
please.
I'll stop my video. So this is the first part of the 3rd module, that is how to approach. You must be seeing right from the module 1 and module 2, having entire presentation on how to approach this woman who is facing any kind of violence. So it's a certain kind of do's and don'ts regarding general violence. Dr. Aki had taken us through a wonderful module. Now this is a woman facing sexual violence. So this module is done by Dr. Jyoti, later curated by me and Dr. Ajay sir. So by definition, sexual violence, you all know, but to define it, it is any sexual act or attempt to obtain a sexual act or unwanted sexual comments or acts to traffic that are directed against a person's sexuality using coercion by anyone, regardless of their relationship to the victim in any setting, including at home and at work. So it's a very, very broad definition. So, and we use the term rape, which is commonly used for the first type of sexual violence mentioned, that is forced or coerced intercourse. And WHO's definition of sexual violence includes, but is not limited to, rape. So by WHO definition of sexual violence, it is defined as physically forced or otherwise coerced by economic means, by psychological means, by whatever means. So it is forced, either physical or otherwise. Penetration of the vulva or anus using a penis or other body parts or an object. So this is the exact definition as per WHO of sexual violence. So the facts are, we know someone who has, the chances are very high that we know someone who has been sexually assaulted in whatever, severity, degree or mode. And generally victims, it's not that commonly believed that you believe that the assaulter is unknown, but mostly victims usually know their assaulter. And victims are never at fault for a sexual assault. We should not, our gesture or talk or comment or our behavior or body language should never be that kinds of hints at blaming the victim for this act of sexual assault. That is very, very important to remember. And rape, though it is widely occurs, it is least reported and convicted violent crime in the world for various reasons, and it is preventable and help is available, and we OB-GYNs play a major role in providing this help. Then forms and contexts of sexual violence, a wide range of sexually violent acts can take place in different circumstances and settings. Like even, within the marriage, forced intercourse can be a rape, or dating relationships, though they are in a relationship, by strangers, then during conflict, then unwanted sexual advances, harassment, in return for favors, maybe you are giving a job or something, and sexual abuse of mentally and physically disabled people in itself is a such a big domain. And then most importantly, sexual abuse of children, which is so grossly underreported. Then again, forced marriage or cohabitation, including child marriage, denial of the right to use contraceptive. You must have seen in Dr. Vindhya's presentation how the husband has prevented the use of contraceptive or even a condom, and repeatedly indulged in forced abortions. And forced abortion in itself is a sexual violence. You have seen in the case scenarios how all of these have occurred. And then violent acts against the sexual integrity of women, including female genital mutilation, though it is not very much in our parts of the world. It is widely reported in Africa, but still it exists. And obligatory inspections for virginity. This also is comes under sexual violence. And forced prostitution and trafficking of people for the purpose of sexual exploitation is a global phenomenon. We all know that. And then customary forms which are more or less accepted in the society, especially things like child marriage, because marriage is often used to legitimize a range of forms of sexual violence against women. And so much so that I don't know if you remember a judgment or a comment saying that a victim of sexual violence, if she is married by the assaulter, then it becomes, you know, consummated in a marriage, then it is almost legitimized. So marrying of young children, particularly girls, in many parts of the world, especially in the old city of Hyderabad, this did happen. And many elderly men take these young girls as wives, and then it is legal in many countries, which is, that is child marriage. It is a form of sexual violence because children are not able to or withhold their consent, and majority of them know little or nothing about sex before they are married. And then what are the consequences? I'll quickly go through this because in the previous presentations, you have seen the pregnancy complications, gynecological complications. STIs are a major part. I think Dr. Vindhya touched upon the HIV part of it, how HIV is intimately related to the sexual violence for various reasons, because the woman is not able to negotiate a condom use, and there is element of trauma and coercion, and the person who is assaulting is generally prone for high risk behavior, and he himself might be suffering from sexually transmitted diseases and mental health issues. Dr. Ramya Madam has beautifully described the mental health issues in victims of violence. Then suicidal behavior and social ostracization, which is really, I think, if there is no confidentiality, then this would be a major deterrent for a survivor to come forward and report the crime. Then it can be fatal. The sexual violence can be fatal. You all must be remembering the Nirbhaya case and then the Disha case, which happened in Hyderabad. There were homicides, and there can be suicides, and then AIDS related morbidity and mortality. Then the non-fatal outcomes, these are all, you know, you name it, you have it. The whole body, mind and soul gets affected, right from pregnancy, infertility, sexual dysfunction, even things like obesity, anorexia, that is mental health disorders, UTIs. And then these are all, you know, these are all symptoms which project in the body physically when there are sexual and mental health issues, migraines, frequent headaches. Then the rape trauma syndrome, post-traumatic stress disorder, social phobias, then shock. Substance abuse is very much known in victims of sexual violence or any violence. Then things like denial, fear, confusion, anxiety, guilt, depression, alienation, and eating disorders. These are all the psychological consequences. So again, sexual assault should be considered as one of the most invasive and intimate forms of violence. As you know, it involves every aspect of a woman's existence, and so the right place is a trauma informed care approach. So there has to be a multi-pronged multidiscipline approach with neurological, biological, psychological and social effects of trauma and violence on men. All these have to be taken care of, not just physical ailments. So when a patient presents and reports a sexual assault, one has to triage the patient as a medical emergency. And then immediate needs have to be assessed, like medical needs, which you obviously will take care of. Then psychiatric evaluation and stabilization. Then community advocacy to the bedside, the NGOs or the help centers or the SHE teams or the bharosas, whatever. Then mandated reporting as dictated by the state statutes. You know that we have to report in case of POXO or assault to the concerned authorities. Then the next part of the module which I'll be covering would tell in detail about this, the sexual assault forensic exam, that is SAFE, how to offer and conduct this examination. Then you have to collaborate with law enforcement if desired by the survivor. Then you have to give prophylactic medications for STI and STD. Then again, risk of pregnancy and emergency emergency contraception, and then safe discharge planning. And those providing medical and forensic care must always be prepared to provide testimony. This is an important part which most of us in public health sectors have the experience of going as an expert witness. So again, writing this final opinion and being prepared to provide testimony is a very important responsibility of us as either a fact or an expert witness. These are all the needs of the survivor of sexual assault. So again, these are 5 principles safety, trustworthiness, choice, collaboration, and empowerment. Safety is, you have to, by your actions, you have to give an indication that you worry or you take care of the safety of the survivor, like by knocking on the door and asking permission to enter the patient's room, then meeting with the parents before they disrobe and ask the patient to disrobe only as necessary and only partially disrobe, and identifying and providing washrooms. Very small little things, but very important to ensure to create confidence in the victim or survivor. Take time to familiarize with the person with the physical environment there, instead of just jumping into interview questions and examination. Ask about comfort level with lighting and how comfortable she's feeling. Then show respect and use a warm and compassionate manner to build rapport. You all have listened to the lives model, definitely. Then trustworthiness is you explain all the procedures in terms the person can understand in before, and tell the person what to expect and how long it will take, and ask the person what he or she wants. Then choice is again asking the choice of the victim before any action, like before you invite the additional staff, before you touch, if you can close the door to, allow the person to decide. Very small actions, but very important. Explain the rationale for each procedure, what the procedure will feel like, and make appropriate modification. Like for example, you are doing a internal examination or you are doing a per-abdominal examination. This is to reduce the re-trauma, already a traumatized patient. So you should take every care and obtain consent for each part of the examination performed. Then comes the collaboration. So it is like a collaborated work, and I think the other departments, other experts also can be taken into consideration where the necessity is there, and also collaborate with the patient regarding sharing the information and to make decisions about treatment. Don't do it unilaterally. And then empowerment. Ask what happened to you, not what is wrong with you. Never ask. Again, this is sympathy, empathy kind of things. Don't put any question or any suggestion as if they imply fault. Take time with the person so he or she feels genuinely heard, and then all these things. So everything, like whatever small thing that you can do or tell the patient matters in these 5 principles. Then comes this is the introductory slide for the next presentation. That is, now comes the examination, the history and examination, medical history, recent consensual sexual activity, assault related medical history, the details of sexual assault, nature of the physical assault, then post assault activities and suspect information. So with this is the basic approach when you encounter a sexual violence victim or survivor. So reminding you of the registration and the post test. So I'd stop this here. Any Ajay sir?
Yeah, we can carry on. Yeah.
Yes. Oh. So this is the main examination of a survivor and collection of evidence. As you all know, examination of a survivor in a respectful manner is important, and equally important is collecting of evidence from the legal point of view, from the medical legal point of view, and also as providers. So you all know that there are laws and there are guidelines, and you all also would be eager to have a simple method which is according to the guidelines. So we made this module taking a lot from the government of India, as well as the state of Telangana has made a module along with the OGSH, our society, and SHE teams. So this is a summary of that important modules. We have abridged, but we have put in all the important things. So what is our role in this? So use important evidence of the crime. That is also important while we are examining, to help judges understand physical and mental condition of the survivor. Use reports to corroborate the survivor's story and enhance credibility. and then offer primary level counseling, treatment and referral for the physical and psychological sequelae. So, and then coming to the medical examination has four important parts. One is recording history, then taking informed consent, documenting all the injuries systematically, then collecting the evidence regarding, which gives information regarding the nature of sexual violence, the time elapsed between incident and examination, whether survivor has bathed and washed. This depends on these factors. Then coming to remember the things, what you have to do is basically they have divided them into 25 points, and the 1 to 11 are the general instructions. Then comes the informed consent, marks of identification, relevant medical surgical history, then history of sexual violence, type of physical emotional abuse, then general physical examination, then comes the examination for injuries overall, then the systematic examination of external genitalia, then systemic examination of other systems, then comes the evidence and sample collection, then comes how you give your provisional medical opinion, then what are the treatments that you prescribe and for what, and then date and time of completion of examination, and then finally giving the final opinion. So this is about medical examination report of sexual violence. You can see here the first 11 points are in this slide. Name of the hospital, OPD number, inpatient number, then name, daughter of, wife of, or son of, whoever it is, where when known, then address, age, date of birth, sex, male, female, or others, time and date, date and time of arrival in the hospital is very important. That means how much time you have taken to examine, and then everything, the date and time of everything is matters a lot. Then date and time of commencement of examination, when they arrived and when have you started to examine. Then brought by, mostly it is police or somebody adults who are accompanying them, their name and signature. You are going to give a MLC number, then the police station which has, under whose purview they have brought this victim, and then whether conscious or coherent, oriented in time, place and person, any physical, intellectual or psychosocial disability. This is important. Sometimes there can be disabilities, both physical, intellectual and social. So then interpreters and special educators will be needed if there are special needs. Sorry. Yeah. Then comes the 12th point, the informed consent. I so and so hereby give my consent for medical examination, yes or no. Medical legal examination, yes or no. Sample collection for clinical and forensic examination, yes or no. I understand that as per the law, the hospital is required to inform police, and this has been explained to me. I want the information to be revealed to police, yes or no. I have understood the purpose and procedure of the examination, including the risk and benefit to be my examining doctor. My right to refuse the examination at any stage, and the consequence of such refusal, including my medical treatment, will not be affected by my refusal, has also been explained to me. So, and may be recorded. Contents of the above have been explained to me in dash language, whatever it is, and with the help of special educator, interpreter, or support person, wherever it is applicable, then his name or signature. So coming to 13th point, that is marks of identification, any scar or mole, and then you take the left thumb impression. Then relevant medical surgical history is onset of menarche in the case of girls, yes or no. Then the age of onset, menstrual history, cycle length and duration, last menstrual period, very important. If she's menstruating at the time of incident, if yes or no. And then at the time of examination also, incident is different and examination is different, both have to be documented. Was the survivor pregnant at the time of incident? If yes, duration of pregnancy, whether contraception use is there or not, what method, then vaccination status of tetanus, hepatitis B and others. Then time of incident, location, then estimated duration is important, like is it 1 to 7 days after the incident they have come, or 1 week to 2 months, 2 to 6 months, or 6 months. Then again episode, this is pertaining to the sexual violence history. Episode is the one, multiple or chronic when it is more than 6 months, or unknown, then the number of assailants, names if they are known, the sex of the assailants, approximate age of the assailants, if known, any relationship to the survivor. And then you ask the description of the incident in the words of the narrator. I mean, whoever is telling this, the same incident, the same description has to be put. And the narrator is, either it can be a survivor or informant. The mother or accompanying person can tell the story and add extra page if necessary. Then type of physical violence, if it is there, and if it is not there also you have to put it. Like most of the times, in order to gain control, they are hit and they are kicked, and they are, burns can be there, and biting, pinching, violent shaking, everything has to be, these are all the things which are there in the pro forma, which we have put up in the slides exactly. So you can just put a tick mark. So burned with, kicking, pulling hair, banging head, dragging. This can happen in case of sexual assault, definitely. Slides are not moving. Okay. Then comes 15. 15 is entirely the description of violence. 15A physical, then B, and then now we come to the emotional abuse. Emotional abuse or violence, if any, like insulting, cursing, violating, all this also is important and has to be documented. Use of restraints, if the survivor has used any restraining object or with hands or anything. Then whether used or threatened the use of weapons like knife or objects, or if any. Verbal threats like threat of killing or hurting survivor also has to be documented. Then luring, like giving chocolates if it's children, like sweets, drinks, alcohol, and any other things. Then any history of alcohol, 15D is alcohol or drug intoxication, whether they were unconscious or sleeping at the time of incident. And then 15E is if the survivor has left any marks of injuries on assailants. Then details regarding sexual abuse. This is 15F regarding penetration. So either by penis, fingers, or object other than body parts. So write yes, don't know, yes, no, or don't know. And also what are the body parts or objects used for penetration. Again, the three organs here involved would be on this side is vagina or urethra, genitalia, that is, then anus and mouth. And this penetration can be either by penis or by any other part of the self or assailant, or objects like other third part like finger, tongue, or any other, or by object. If so, what object? Then if it is associated with emission of semen, yes, no, or don't know. These columns help you to very clearly without you having to think of everything. Then details regarding again sexual violence, oral sex by assailant, yes, no, or don't know. Forced masturbation of the assailant by the survivor. And then exhibitionism, did ejaculation occur, whether outside body or if yes, where on the body, whether condom was used, what is the status of the condom, lubricant used, if yes, what any kind of lubricant, if any object is used, description of the object. So this concludes basic history description. Then what happens after the incident also has to be documented, whether they have changed the clothes, changed the undergarments, cleaned or washed clothes, cleaned or washed undergarments, bathed, dodged, or passed urine, passed stools, whether rinsing of mouth or brushing or vomiting. Circle any or all are is appropriate. Yes, do, yes, no, or do not know. And then time since incident and other remarks. Any discharge is there, any bleeding is there, any painful urination, defecation, abdominal pain, pain in genitals because of the trauma. So all the organs involved have to be specifically, the symptoms have to be asked. Coming to the general physical examination, height, weight, build, gait, pulse rate, blood pressure, temperature, respiratory rate, any other thing that you notice. Then coming to the examination, if you put these questions, what injuries, where are they, how are they? Then what are the injuries? They are bruises, nail abrasions, teeth bites, cuts, lacerations. You have to clearly mention what are all the types of injuries. Then where on the body parts, right from scalp to thighs, buttocks, etc. And then how, the size has to be mentioned very clearly, shape, color, any swelling, any signs of healing, whether the injuries are simple or grievous, along with dimensions. Then coming to the external genitalia, describe the condition of the majora, like labia majora, minora, urethral meatus and vestibule, fourchette and introitus, perineum, hymen. Pervaginal and perspeculum examination should not be done unless required for the detection of injuries or for medical treatment. So if performed, mention and also record reasons for the perspeculum and PV. And then notice and mention about bleeding, tear or discharge, edema or tenderness in the anus, rectum and also oral cavity. The importance is not just genitalia, we also have to notice and examine anus, rectum and oral cavity. Then there comes the systemic examination. Don't forget to examine the other systems like CNS, CVS, respiratory system and abdomen. Coming to the most important part of the evidence collection. Why do we collect samples? One is to obtain confirmation of the allegation, to establish the link between the victim and the scene, and to establish the link between the victim and the assailant. And remember that every contact leaves a trace. So the principles are: maintain the chain of evidence, identify the specimen, label the specimen, sign the label, and record the disposal of the specimen. These are very important. Then coming to the sample collection investigations, the routine hospital laboratory, clinical laboratory like bloods for virology, urine test for pregnancy to rule out pregnancy, then ultrasound for pregnancy or any internal injury, any case if there are any suspicion of other injuries. Then coming to sending to state or central forensic laboratory, then debris collection paper and clothing evidence where available, which are to be packed in a separate paper bags after air drying. So what are on the swabs? From the stains on the body, scalp hair 10 to 15 strands, then head hair combing, nail scrapings, both hands separately, oral swab, blood for grouping testing for drugs, alcohol, blood for DNA analysis. This is where necessary. Then urine for drug testing, again where necessary if there is history or influence of alcohol and drugs. Any other, like if there is a tampon or a sanitary napkin or a condom, again they have to be collected. If not collected, the reasons also have to be mentioned. Then genital and anal evidence, each sample has to be packed, sealed and labeled separately to be placed in a bag. Like matted pubic hair, its pubic hair combing, mention if shaved, cutting of pubic hair, mention if shaved, 2 vulval swabs for semen and DNA, 2 vaginal swabs, semen and DNA, 2 anal swabs for semen and DNA, vaginal smear, which has to be air dried for semen examination, urethral swab. These are all the swabs which have to be taken, preserved as directed till handed over to police along with the duty attested sample seal. And if not collected for any reason, just mention the reasons for not collecting. Then comes the final provisional medical opinion. I have examined this so and so, aged and reporting so and so type of sexual violence under so and so circumstances, so many hours or days after the incident, after having either bathed or number of times. Then my findings are as follows. Samples are collected for FSL awaiting reports, samples collected for hospital laboratory, and then clinical findings and additional observations. Now comes before the other thing as final opinion, you have to treat this victim or survivor. So what are the important things? STI prevention treatment has to be given. If necessary, if you feel so, emergency contraception has to be given. The wound treatment has to be given. If there is no tetanus toxoid prophylaxis documented, you have to give a shot of TT, then hepatitis B vaccination, then post-exposure prophylaxis for HIV, then counseling and others. Then finally, date and time of completion of examination and end with this report contains so many number of sheets and number of envelopes. Finally, you sign and write your name and place the seal. Now, after receiving lab reports, then you get the final lab reports from forensic. Now you are supposed to give the final opinion. This is very important because most of the times when we were, still professional, we didn't know exactly what to write. We used to take the advice of seniors, and most of the times we would write there is no evidence of or recent evidence of sexual intercourse, or there is indirect some kind of which was very vague. So there are clear-cut 11 opinions which can be given. So 11 opinions depending on the conditions which are there on the right side. There are injuries and there are motile spermatozoa. Then there is no doubt you are going to write there is evidence of recent sexual intercourse. There are no non-motile spermatozoa in the vagina when the report late, and there are partially healed. That means they have come late. Then you have to write remote sexual intercourse. There are local injuries to genitals, but there are no spermatozoa or recovered, whether they are using condom or vasectomized or other reasons. Then you can, you have to mention there is recent evidence of recent penetration. When local partially healed injuries to genitals and no spermatozoa are recovered, there is evidence of remote penetration. Likewise, there is evidence of recent sexual assault when there are injuries on the face, cheeks, etc. But injuries to genitals are absent. So that is when help is arrived before the actual penetration has occurred. Then evidence of remote sexual, again partially injured, healed injuries on other aspects of face, etc. But injuries to, that is absence of injuries to genitals doesn't preclude sexual assault. That is important thing to understand. And there is no evidence of vaginal penetration, but possibility cannot. This is what most commonly, possibility cannot be ruled out. But that is done when there are no injuries and no spermatozoa are recovered. You are not able to see the injuries, not able to see the spermatozoa. Even then, you are not committing that there is no evidence of sexual assault. You are saying there is no evidence of vaginal penetration, but possibility cannot be ruled out. That is, you are giving all the benefit of thing to the survivor. So when recent injuries are noted and metal spermatozoa are recovered, that is, this is regarding oral anal intercourse, similar to the vaginal. So these are all the 11 opinions, very important. So findings in support of the above opinion, taking into account the history, clinical examination, findings and laboratory reports of bearing identification marks, again hours and days after the incident of sexual violence, I am of the opinion. So here comes your one of the 11 opinions. You sign and then you write, and then this entire copy has to be given to the survivor or victim free of cost immediately. The summary is, take informed consent. You don't do the vaginal examination or two-finger test, not to be done. Hymen or size of vagina, etc., not to be commented. Then you document in detail all the injuries, collect the samples, and then give the final opinion after receiving the lab reports. And this algorithm is very important. So after doing the age estimation, physical, dental, and taking the consent, you take history and examine. Then in the examination is age, physical, dental, radiological, and then next important is evidence collection. You dry pack, seal, and hand over to police, and then after, you immediately give treatment regarding what? Injuries, STIs, HIV, emergency contraception, UPT, and then counseling and information and referral to other services. This is all part of your treatment. Then you document, then you discharge and follow up. These are the comprehensive response to sexual violence, and these have to be carried out in all the cases. So these are annexures. Not go through it. Actually, we'll give the resources at the end of the last slide, which has they're available on net. So one is the Government of India guidelines, Ministry of Health and Family Welfare, and then the other one is by the state of Telangana and OGSH. So these are our acknowledgements and references. With this, I end my presentation, and if any doubts, queries, or comments are there, kindly share.
Thank you so much, Kiranmai, for making such a difficult topic so easy. Everything has been comprehensively put at one place for everybody to be able to understand and take out the critical points over there. Kiranmai, are you there? You're frozen.
Yes, sir. Yes,
Okay.
yes, sir. I'm here. I was just checking the chat.
Okay. Yeah. Thank you so much for doing this, Kiranmai. And there was a question in the chat box, Sweetie. There are no further programs, TOTs for Dheera school program. However, you can still join the program by getting schools on board. Once you have the school on board, one or several schools on board, let us know. The email I have already put down there, dheera.wow@gmail.com. Let us know and we will guide you, handhold you at every step to take the process forward. So all the very best. We look forward to making sure you also get some schools for us. So it's not that you're not a TOT or a master trainer, you cannot be involved. You can still be involved and lead the session taking forward. Other than that, I don't think so there are any other comments or any other questions there. I would leave the floor open to the faculty if you have some last closing remarks. And I will request Sriman to please go ahead and post the post test over here in the chat box so that all participants can click on it and submit their post test. Dear all colleagues, I would also request you to please, I've shared the email dheera.wow@gmail.com. Which President Dr. Shanta Kumari has so kindly, negotiated and made sure it is available to each one of you who is participating over here. In case you do not want to take the honorarium, which is also fine, but you still have to drop one line mail saying that you do not wish to take the honorarium and that it should be retained by Foxy for further work. It is important that we have this, okay? So you take it or you don't take it, either which way, banking details, send it if you're taking it. If you're not taking it, send us a one-line mail. Any comments from the faculty? And then we can invite any other comments from,
Dr. J, yes, excellent presentations. All of them were very explainable. The only thing is, can we have PPTs, because some do require repeat reading, because like physical examination, etc., are there in the government guidelines, but there are many who have been made beautifully, and it will be nice if we are able to read them again also.
Yes.
So
certainly.
I don't know if there's a provision, then we can have it.
There is definitely a provision. You being the master trainer means you all being the master trainers, all of you will be getting a copy of these presentations, and you will have to lead these programs in your respective societies or any other societies whom which we invite you on first come first serve basis to join those programs and take these topics. We will also be sharing with each one of you a recording of today's session so that you are able to also review it for the topics that you're likely to take. Sriman has already posted the post test over there. Click on that link and you will be able to submit your post test. Dear faculty, you have anything else to add? Please, Kiranmai, or I can now see Deepa is there, Jyoti is there, Ramani Devi I can see. Any comments you have? Would love to hear it. Otherwise, we can call the session to a close. And Kiranmai, I must, and all the faculty, I must really applaud each one of you, because, the first session we went overboard in terms of half an hour time slot. I think this time you have done a fantastic job to be within the time frame.
Sir, Dr. Milinsha is muted. We're not able to hear you.
Ajay, I have one question. Actually, I am interested to go ahead with the school adolescent programs, but I have not done the trainers training.
No worries, even if you're not trained, we have 600 master trainers from across the country. We have several who are there in Marathi from Maharashtra itself. So if your school is a local school, government school, or Marathi speaking school, we will be able to get faculty for you and arrange those faculties in Marathi.
Okay, but can we have that training again?
Yes, master training is not happening because we have completed the quota. But you can certainly rope in more schools. Send us an email on Dheera Wow, and we will help you completely.
Okay, thank you so much.
I'm really looking forward to Vidarbha contributing majorly in terms of schools.
Right, thank you.
Dr. Ajay, what we are getting, are we going to be master trainers or what?
This today program, each one of you participating will be the master trainers. You will be conducting the sessions going forward.
Yes, so we can now conduct the programs or wherever it is.
Yes, wherever it is, we will invite you. We will create the programs. We will invite you. You can also do the program directly. Let us know and we'll allocate the Zoom and other faculty for you.
Sir, I just wanted to ask, will it go ahead like RAC now? Societies wise?
Yes, it will go ahead as RAC, society wise. Each and every society can participate. Multiple societies can join hands together and do the program. And the only non-negotiable is registration, pre-test, post-test, and feedback. So everything has to be done under the aegis of Foxy President, because this is a Foxy program led by our president. So whatever you do has to be within that banner.
Dr. Indira was asking whether they can attend as not as master trainers. I think just now Ajay sir has clarified it. So going ahead, we'll have training sessions for other members, not as master trainers, but just to make them aware of the module so
Yes.
that they can be called as trained. So we have few people here who are really. Dr. Shruti Patil is there. I think she's from Gadag. She expressed. She spoke on that. She was the Kamini Rao orator from the south on the topic of the same president's Dheera no to war and all. So, and we have Vartika also, Meeta, many active people are there.
Yeah, I recall Vartika's name coming up often. My only grouse with Vartika is that she has not taken a single program.
Sir, I took one.
Yeah. One program. Vartika, we need more.
Although 125 programs have happened, 125 program into 4 trainers per program, meaning 600 people have taken. I know who has taken which session out of the 600 and how many schools have happened. So it is out of sheer concern and love for the program that I do it, and we all have done it and are doing it. So my humble request with folded hands, please take these 2 processes forward, both with the school and with this OBGYN, and we as a team, all of us, including Sriman, who is in the background, will be supporting you completely to make sure it happens for you.
There is problem in date, sir. In the post page, date is not taking.
You're breaking up.
I have filled the post, but date is not saying that 5/5/2022. I'm entering, but it is not, so invalid date.
I couldn't hear it. Kiranmai, could you hear it? What is it?
Something with the post test. She has finished and entered the date, today's date, and it is not taking up, saying it as invalid date. You have put it in the required format, Doctor.
Yeah. I have put in correct. It is 5/5/2022 today.
No. It will be 05/05/2022.
0505. I think your format.
What is this 05? I was listening to the conversation.
Today is the
So
date.
we have to write 0505.
It will not accept 55. It will accept 05/05/2022.
The way we put the date.
Okay.
Maybe it is already there in the chat box there. Let me repost it. Sriman, I'm not able to copy it. Can you repost it, please?
Yes, sir. I'll do it again.
Okay.
I have put it again. Yeah.
Thank you. So with that, if there are no Kiranmai, would you like to please give the final remarks? Do you need to close it? Or if Rakhi is there, both of you, any one of you could do it. Go ahead, Kiranmai. I think Rakhi is.
Dr. Rakhi. Yeah. So basically, you must have there are these 2 prongs. One is sensitizing and educating the young students, catching them young and teaching them about what violence is and what they do and all. And this is sensitizing our own fraternity, not just being aware, but because WHO says you can take up screening and care of these women once you have received some basic training. So that is what the madam has. We all were trained by the UNICEF module in the. So that model, most of it, and along with our Indian scenario and all, has come into our modules. As you can see, from physical violence till sexual violence, rape, and how to examine, and all the basic principles of our approach to the patients. The do's and don'ts are most important. I think we all want to help, but unknowingly we kind of do the wrong things or don't do the right things. So that is the major important part of this module is what I feel. And also the challenging situations, mental health, and self-care for ourselves. So most of the time we forget about ourselves. So that also has been put into this. So all in all, it's a very comprehensive module. I would say even more comprehensive than what we have seen in the UNICEF module, though it is extensive, 2 days and all, but this is a very comprehensive,
domestic
very
violence
essential module.
सभी से तो कर सकते हैं प्रोटेक्शन ऑफ द सर्विस प्रोवाइडिंग सेंटर मेडिकल ऑफिसर इंचार्ज से, लेकिन थोड़ी जरा देखो इसका आंसर देखो। पुलिस स्टेशन में कंप्लेन कर सकते हैं, मजिस्ट्रेट को कंप्लेन कर सकते हैं।
I think, yeah, okay. Thank you so much, each one of you. Each one of you have a wonderful evening, and we'll catch up more tomorrow. Kiran,
Madam is
I may be running late tomorrow, so I don't know if you are available tomorrow from the start of the session. Then if you are, Raki, you are there, can you please lead the session tomorrow? Because I may be running late tomorrow.
Yeah, I'll join, sir, but at least the first half an hour I would be in transit, I think, but I'll try to join from my car.
Okay, okay.
But if Dr. Raki or anyone, I'll be there. I'll try.
I'll put it in the group. No worries. Okay.
Yes.
Is it same or another?
H1, all the very best. Thank you so much,
Bye,
faculty.
sir.
Thank you so much, everyone.
Thank you, sir.
Jamuna
Bye,
madam,
everyone.
Thank you, Aruna. Thank you, Jamuna.
Aruna,
Janna
thanks,
madam.
Aruna, for joining at
Thank you,
short notice.
Thank you so much.
Yes, Meeta. Want to say something?
Yes, ma'am.
You wanted to say something?
Ma'am, we just want to thank you, ma'am. This is very comprehensive, very well explained.
Thank you.
Thank you, ma'am. Thank you.
Thank you, Meeta.
Thank you so much,
Looking
ma'am.
forward. Yes. Yeah. Bye.
Tomorrow the session will be for others, no? Hello? Hello?
Yes, madam.
Tomorrow the session will be others or for others only. We have
For others,
finished.
but if you want to join, you can again you have to register, madam.
Okay, this session only, no?
Yes, madam.
That we have attended. Okay, thank you.
Welcome, ma'am.
And certificate? Hello? Hello?
Yes, madam.
What about certificate?